Okay, welcome back today. Welcome to lab. For those of you that were not able, they didn't get my message. We didn't have lecture today. My wife had an asthma flare-up, and since with COVID and everything, we had to go to the doctor this morning at 11 o'clock. It was the only time we could get in. So I apologize for that. She did not have COVID, so that was good. And despite having had both of her vaccines, there's always a concern. Anyway, today in lab, we're going to take a look at human blood. Do you have any questions on anything up to this point? No questions at all. Okay. So let's go ahead and then let's go ahead and get started. We're going to take a look at human blood. We'll be done with lab as of today for the first unit. And I still anticipate on Wednesday in lecture, we will start reproduction. Instead of starting it today, we'll start reproduction. And then I'll open up the first lab test for you. Let's see, the lecture test ends, well, I'll open it, I guess it's this week. I'll look at the schedule. I'll make sure they don't overlap. So we won't have two hanging out there at the same time. Get one in here. Okay, let's go ahead and share screen and get into blood. Okay, human blood. Blood, of course, is our internal transport system. This shows blood cells, red cells, moving through a capillary. We have an incredible system of transporting blood around our bodies. It actually only takes about 20 seconds, though, for a red blood cell to leave the heart and go through the entire systemic circulation and return back to the heart. So in 20 seconds, it's made a complete pass through the body. And something we'll talk about in lecture is that the oxygen content in those red cells is only reduced by about 20% on each pass. So we have a pretty big reserve there. So even though we say the blood becomes, red cells become re-oxygenated when they go to the lungs, that sounds like they're losing all their oxygen, when really all they're doing is being topped off back to 100%. One pass through the body takes about 80% saturation. And the advantage of that is we have plenty of reserve in our blood. If we used up all of our blood in every pass through the body, we'd have no reserve. You would not be able to climb a flight of stairs. You would not be able to do any kind of exercising of any kind, do any kind of work, because you would be exhausting all your available oxygen on the simplest procedures. So what does blood look like? Well, we know it's red. As we see here, it is sticky. It is opaque. You can't see through whole blood. It has a metallic taste to it because of the presence of the iron. It is more viscous than water, so blood is thicker than water. Its pH ranges between 7.35 and 7.45, somewhere around 7.4. It is slightly alkaline. If you remember from AP1, we talked about the pH scale, and on the scale it showed human blood at 7.4. And that's where blood likes to hang out, because blood's always dealing with carbon dioxide forming carbonic acid. And if we are slightly alkaline, It helps to neutralize some of that carbonic acid. However, we don't want to, we have to stay in balance. That range, 7.35 to 7.45, is the only leeway we have in our pH scale. Within that range, we're operating fine. Outside that range, even a little bit either direction makes significant changes in the body. Temperature, it's slightly warmer than body temperature. It's 38 degrees instead of 37. And it's red, but it can be various shades of red. The more oxygen that it carries, the redder it's going to be. Blood that's fully oxygenated is bright, brilliant scarlet red, sort of like you see in these red cells here. Blood that is lower in oxygen is a darker red. The blood that we usually see that when we cut ourselves and we're bleeding, that blood is venous blood, the return blood, and it's always about 80%, 75% saturated, and it's darker red. It has less oxygen there. Still has plenty to give out if needed, but it has less. So the presence of the oxygen makes the hemoglobin turn a brighter shade of red. So the amount of blood makes up about 8% of our body weight. That's a hard-hitting factoid. And the average volume varies simply by general body stature. Males have between 5 and 6 liters. The average female has between 4 and 5. And this can be variable. You know, that is not a hard and fast number. You know, it all depends on body stature. It's okay, Brian. So now the blood, what's its purpose? Well, for distribution, oxygen, nutrients, waste, and hormones, regulates body temperature, it adjusts our pH, it maintains our fluid volume, and it protects us from infection and from blood loss. It transports oxygen, obviously. It transports nutrients to the cells. Nutrients, the glucose, for example, is in plasma. You know, the number one nutrient for the body is glucose. Glucose is in solution in the plasma. We call that the blood glucose or blood sugar. We still call it blood glucose. And you know, as the plasma leaks out and becomes interstitial fluid, the glucose goes with it. And the glucose then will enter into the cells that the interstitial fluid surrounds through facilitated diffusion, thanks to insulin. Insulin causes cells to open up their cell membranes and glucose comes in. Blood also picks up waste products from the cells. All the nitrogenous waste from the breakdown of proteins, all the debris and pathogens and you know, whatever. You know, cells die all the time. Cell fragments are always removed and taken to the kidneys for eliminating. And of course, all those hormones that we see get released from the endocrine glands are transported through the fluid portion of the blood, and they ooze through the capillaries and penetrate the cells, going through the interstitial fluid if they penetrate it, or they use a second messenger or whatever. But that's how the hormones get distributed through the plasma portion of blood. We maintain our body temperature by moving blood around to absorb heat or to radiate heat. On a hot day, your blood flow would increase to the surface of your skin so that we can give off heat. On a cold day, we reduce the flow to the skin so we have less blood going to the skin cells, and so we radiate less heat from our skin. We use our blood to maintain our pH. We have buffers that respond to an increase or a decrease in pH. If we get too acidic, we're going to release more sodium bicarbonate to neutralize the carbonic acid. If we get too basic, we're going to produce more carbonic acid to neutralize the increased alkalinity of the blood. And we keep a set volume of fluid in our circulatory system. Our heart has a hard time pumping blood if there's less fluid volume there, because the cells have to float in something. And protection's a big thing we focus on now. We haven't got into the discussion about the immune system and antibodies yet, but we will later in the semester. We don't want to, first of all, we don't want to lose blood. You know, if you have an injury, if your patient has an injury, they're going to bleed. Blunt force trauma, it can be internal bleeding, it can be a laceration on the skin that causes bleeding, they're going to bleed. And if we don't stop the bleeding, as most doctors will tell you when they're trying to make a joke, all bleeding stops eventually. We don't like to bleed. And so we have mechanisms available to stop the bleeding. We have proteins in solution that will become activated and form a clot to stop bleeding. We have platelets, the cell fragments, the third component of the living cells, that will become activated and condense and form a plug at the site of an injury. The other thing our blood does is it fights infection. Antibodies produced by our B cells, the B lymphocytes produce antibodies. Antibodies glom onto foreign pathogens, foreign cells, foreign structures. The antibodies are going to be attracted to the antigens on foreign bacteria or foreign tissue. Antigens, if we go back to AP1, we talked about the glycocalyx. So glycocalyx is essentially a sugar-coated protein on the surface of a cell. We use glycocalyx structures as identifiers to identify our cells as self, so that we leave them alone. We don't attack them. However, pathogens, foreign bacteria, whether they're a pathogen or not, viruses all have, and viruses and funguses all have foreign antigens that we don't recognize. Our immune system can recognize every antigen on the surface of every cell in our body and say, hey, that's us. It's how blood typing works. We recognize antigens. And so we don't attack our cells. Foreign cells don't have the same antigens and will attack them. Transplanted tissue doesn't, unless it's from a close family donor, is going to be recognized as foreign and going to be attacked. You know, there's always the issue of tissue rejection when you do a transplant. So we have to respond to that. So we produce antibodies, we produce proteins that will block the action of a pathogenic bacteria. We produce white cells that will go out. You know, the T cells are going to be the killer cells that go out and hunt down pathogenic cells, bacteria, viruses, because viruses aren't cells, and destroy them. They're also going to have the B cells, which produce the lymphocytes, targeting other cells for destruction. So this is how our immune system works. White blood cells, the T cells, are the killer cells. They will hunt down bacteria and destroy it. This is a white blood cell here, likely a T cell, but it will engulf the bacteria. And there we go. We've engulfed the bacteria, and now the bacteria is going to be destroyed inside the white cell. So when we have foreign, when I say foreign, it doesn't necessarily be pathogenic. It's a foreign bacteria, because we have our own bacteria on our skin that we call our indigenous bacteria. It's our bacteria. It's our pet bacteria. And this foreign bacteria will get destroyed by our white cells. And we can flood an area with white cells. We see whenever we have an infection, we see a rise in white cells to kill or destroy any kind of foreign invader. Blood is still connective tissue. We talked about that back in AP1, in AP1 lab. It's probably the first lab we had in AP1. We talked about connective tissue. And connective tissue has three criteria. It has to be living cells in a matrix that can be a solid, a liquid, or a gel with fibers. And the matrix is the plasma. The cells are the formed elements. We have red cells and white cells, and we have the cell fragments like the platelets, but they're in there too. So we have the white and red cells. And so the formed elements in our blood are the red cells, the erythrocytes or red blood cells, or RBCs, leukocytes, white cells. We have 5 different types of white cells, called them white blood cells or leukocytes. And then we have the platelets, which are the fragments. So we have the matrix, which is plasma. We have the formed elements, the red cells, white cells, and platelets. And we have the fibers, which are in solution. I'll get to that in a second. The red cells, white cells, and platelets are the formed elements. The white cells are the only ones that have, complete set of organelles. They have a nucleus, they have organelles, they survive, they run through a cell cycle, and they can reproduce. Some do, some don't. Red cells have no organelles. Red cells have no nucleus. Red cells are nothing but a sac of hemoglobin, and it will survive for about 4 months and then break down. Red cells initially had a nucleus, but before they were released from the bone marrow, they kicked their nucleus out to have more room to carry oxygen. And so we have, so the red cells have nothing. They have nothing there except hemoglobin and oxygen inside this sac. And then the cell fragments are the platelets, and they are broken off from a larger stem cell. Now it says that all blood cells or most blood cells come from the bone marrow, which is true. All 5 different types of white cells come from the bone marrow. The red cells come from the bone marrow. The platelets come from the bone marrow. Most don't divide, but some do. Some of the lymphocyte cells will continue to divide. If you look at whole blood, it's red. You can't see through it. If you were to spin it down in a centrifuge, you would have 3 layers. You'd have a dark red layer, which are the packed cells, the packed red cells. You'd have a clear layer that is looks sort of like sort of a pale yellow. And then on top of the white cells, you'll have what's known as the buffy coat layer. The pale yellow layer is the plasma. The red layer are the packed red cells, and the white cells are sitting on top of the red cells, what we call the buffy coat. And so our plasma is about 55%, and red cells are about 45%, and less than 1% is the buffy coat. It looks like this. There we have we took our blood out of a person, put it in a centrifuge, spun it down, and it looks something like this. Plasma on top, buffy coat, and erythrocytes here. And for real, this is what it looks like, whole blood. And a sample of whole blood that's been spun down in the centrifuge with the plasma on top. The red cells are the most dense because of all the hemoglobin that they're carrying. And then the white cells are on top of that. Because there's so few white cells. Because if you have in a sample of whole blood in a deciliter of whole blood, which is 1/100th of a liter, you would have typically 5 million red cells, 5,000 white cells, and about 3,500 platelets. Platelets don't play by the rules as far as numbers go. 55% plasma, 45% red cells, about 5,000 red cells, about 5 million red cells, about 5,000 white cells. The plasma is mostly water. It is 90% water, filled with proteins, the albumins, the same protein that's in egg white, plus the globulins, the fibrinogens, and the prothrombins. Those are your fibrous proteins. They are in their inactive state. The fibrinogen and prothrombin have to be converted from for clotting to occur. Prothrombin has to be converted to thrombin. Thrombin then converts fibrinogen to fibrin. So it's a multi-step process to take these soluble proteins and convert them into solid fibers in solution. Plus, you carry your enzymes, your hormones, and your nutrients in here. You have all your electrolytes, the sodium. The bulk of the sodium in our bodies is found in our plasma and in the interstitial fluid. So most of the sodium in our bodies is outside the cells. Most of the potassium is inside our cells. Waste products show up in the plasma, as do the buffers, the carbonic acid, the sodium bicarbonate, for example. Term here, hematocrit. Hematocrit is what percent of the blood is taken up by the red cells. Because when we're dealing with less than 1% of the white cells, that it's hard to have a quantitative measure of the percent of white cells just from a spun sample of blood, because that little buffy coat layer, you can't give an accurate reading on that. However, the hematocrit is the percent of the blood sample that's made up by red cells, and the average individual is about 45%. The range goes from 40 to 54%. We say, right around 45, 46% is the average value, and about 55% then of plasma. So we don't really pay attention to the white cells in this type of sample. Female hematocrit is typically lower than males, simply because of the presence of estrogen. Estrogen does not do anything to increase or stimulate red blood cell production. Testosterone does. So males have a slightly higher red cell count than females do, simply because the testosterone in males stimulates red cell production. Estrogen, the other sex hormone, doesn't. Now, what good is a hematocrit? Well, a hematocrit can give you an idea on, does your patient have the appropriate number of red cells? It's all sorts of conditions that affect the production of red cells. This is sort of it's semi-quantitative, it's almost qualitative, in the sense that if you see an excessive number of red cells, that's not good. An excessive number of red cells may indicate a condition known as polycythemia, where your bone marrow is making too many red cells. And underabundance, too few red cells, a hematocrit below 45 or below 42 may indicate maybe a symptom of anemia. And anemia, of course, is a symptom itself. So anemia may be occurring because there's not enough red cells. So then, of course, the anemia is a symptom. What's causing the lack of red cells? So we do a hematocrit value on whole blood. One of the first lab tests we do on the blood is to see what the hematocrit is. red cells too high, red cells too low, or red cells just right, somewhere in that 42 to 45 range. This is what a centrifuge looks like. Centrifuges like this are probably still in use, but you collect the sample in a very thin glass tube called a capillary tube, and the capillary tube works through capillary action. You lance the person's finger, and the very, very tiny cut and just enough for it to bleed, and you place this capillary tube on the blood sample, and the blood is drawn up automatically into the capillary tube by what we call capillary action. Blood moves up into the tube, and then you can seal that tube, stick it in the centrifuge. They're very small tubes. They fit into a little groove right in here. Lock it down, spin it for about 10 minutes or so, and the blood separates out by plasma, white cells, and red cells. We call it a microhematocrit centrifuge because these capillary tubes are very, very tiny. So you can see just what the tube looks like. You can see how small it is. So you spin it down, and you look at the, you can then measure the percentage of whole blood, of red cells and white cells and the plasma. Usually the amount of white cells there is too small to to actually, get a good quantitative value. So here's the breakout. The plasma, 55%, the water, the proteins, electrolytes, the nutrients, waste products. The Buffy coat, red cells, white cells, and platelets, and hematocrit are all the red cells. A person that is experiencing anemia will have a depressed hematocrit, and you'll see a lot of plasma and fewer than normal red cells. A person with polycythemia, which is overproduction of red cells, will have very little plasma and lots of red cells. So their hematocrit is high. We don't want to be too high or too low. And these readers are very simple. Even the basic type of reader is still in use. It can be scanned in a machine easily, but these readers are very, very simple to operate. You take your sample, place it in the reader, and then you move this up and down, and that moves this bar. This little white line lines up at the Buffy coat, and everything above it is the plasma, and everything below it is the red cell. And in this case, it looks like this sample has about 80%, has a hematocrit of 80%, meaning that they're probably experiencing polycythemia. So we have various examples here of blood that's been spun down, normal, elevated, depressed, again, elevated and depressed right here. Very simple procedure to do this. It's pretty old school, but it is just as effective as technology. Technology is probably faster, and that's fine. This still works. Because again, it's pretty hard, even though you're going to be doing it subjectively by looking at it and making your best estimate, it's hard to get it wrong when you're lining up this line where it crosses the layer between the plasma and the red cells. So it's not the same mistakes can happen. Anyway, that's the hematocrit. It gives you a good idea of the level of the amount of red cells and plasma in your blood sample. And that can give you an indication of what's going on. Are they experiencing anemia? Are they experiencing polycythemia? Or is at least their hematocrit level normal? Now, these are called sedimentation tubes. Erythrocyte sedimentation rate tubes. They measure the rate, how fast red cells will clump together and drop to the bottom of these tubes in a set time frame. Red cells will drop to the bottom of the tube faster if there is an infection going on. Inflammatory chemicals are released into the blood during an infection, and they cause the red cells to clump together. And when they clump together, they drop faster. So now again, all we've done is take a sample of blood. We haven't done anything else, but we're assessing, are there too many red cells or too few red cells? Or are they just right? What's the sedimentation rate? Sedimentation rate high, sedimentation rate low, sedimentation rate normal. This is how fast red cells will coalesce and collect. Sedimentation means to drop to the bottom of a tube, to collect, like sedimentary rock, sedimentary layers. It's like when if you are setting up an aquarium and you have all the sand in place there and you dump water in on top of it, and all the sand goes into the water and then gradually settles back down into the bottom of the aquarium. This is sedimentation. Red cells do this. It is a measure of inflammation or infection in the body. Doesn't say where it's coming from, but if the red cells drop rapidly, faster than normal, then this is an indicator that something's going on. And so we say, okay, the sedimentation rate is this: too high, too low, or normal. How does it work? Well, when there is an inflammatory response going on, when our bodies are responding to an infection, we call it the inflammatory response. But when there's an inflammatory response going on, fibrinogen, the plasma protein that causes blood to clot, the fibrinogen levels go up during an inflammatory response here in response to an infection. The fibrinogen levels go up and they make the red cells sticky. And the red cells start sticking together in here, and that makes them clump. We call them rouleau formations. They look like, you ever eat Pringles chips? You know how you open the can and pour them out, they all come stacked together right on top of each other? That's what red cells look like in rouleau formation. And so the sedimentation rate will increase if there's some sort of inflammation or infection going on here, thanks to the high concentration of fibrinogen. And so they look like this. Some say it looks like stacks of coins, but I think the Pringles analogy works pretty good too. This indicator says, okay, we have an inflammatory response going on somewhere. We are fighting an infection or an allergic reaction somewhere. We're fighting an infection or an allergic reaction. Do we have something going on here? And this tells us, this is an indicator. It doesn't say where, it doesn't say what, but it's an indicator that something is going on that shouldn't be. We shouldn't see red cells that look like this in a sedimentation rate tube. Again, they clump. This is an illustration, but they clump together pretty drastically here, and that makes them heavier. So the blood cells sink down to the bottom of the tube at a faster rate. So we've looked at hematocrit, we've looked at sedimentation rates. Next thing to look at is a measure of the hemoglobin. Measure the hemoglobin in our blood. Hemoglobin is the protein. It's a quaternary protein. If you remember back to AP1, what proteins come as primary, secondary, tertiary, and quaternaries. It's a big molecule. It has iron at the center of it to carry 4 oxygen atoms. Hemoglobin is packed into the red cells, and we use the hemoglobin to carry oxygen in the blood. Blood has been brought up to 100% saturation in the lungs, ideally, transports that oxygen inside the red cells throughout the circulatory system, Oxygen diffuses into the blood, diffuses across the membrane of the capillary, diffuses across the membrane of the cell, and the cell gets oxygen. Diffusion works because we always go from high concentration to low concentration. So we always want to know what is the hemoglobin saturation in our blood, because this is another way to determine if do we have enough red cells. It tells us, do we have enough red cells? If we don't have enough hemoglobin, we won't have enough red cells. We don't have enough iron, we won't have enough hemoglobin, we won't have enough red cells. So there's all sorts of things that knowing the percent of hemoglobin can tell us. Usually we see a hemoglobin count done. If you've ever had, the blood workup, you go into the lab early in the morning, you haven't had breakfast, you haven't had anything, nothing to eat after midnight. And so they stick you and take your blood, and then you can go get something to eat and drink. And you get what's known as a complete blood count, a CBC. They measure all white cells, different types of white cells, how many red cells, how many platelets, they measure glucose, they measure hemoglobin. And this machine here is what's known as a hemoglobinometer. It is a visual way of measuring hemoglobin. Now, the only thing wrong with this, and a couple of other ways here, is that they're pretty subjective. They depend on our eyeball and our judgment to make give us a valid number. And it usually works. It makes us, we're close. We may be spot on to the right number, but it's all subjective. Every one of us may read the same piece of information and get a slightly different take on it. So that's the only thing wrong with using these individual devices like this. Now, hemoglobin measured in grams per deciliter. Well, a deciliter, of course, is 1/100th of a liter. It's 100 milliliters. Males have an average hemoglobin between 14 and 18. Females have an average between 12 and 16. Probably driven by body stature. It may be driven by estrogen and testosterone. I think it's more body stature than anything. Hemoglobin levels tend to drop somewhat as we age. Your patients that are past middle age will have slightly lower hemoglobin levels than people younger than that. So probably has more to do with protein synthesis and the manufacture of hemoglobin than anything else. So variety of ways to measure hemoglobin. Well, we have these great devices now that are so simple that you can take a sample of blood, put it on in this little tube here. Just take a blood sample right off the lancet on the finger. You can't get away without sticking people with a lancet to one of those little probes to get blood. You can't get away with that, but it's not invasive. You're not going to go inside. Put a drop of that blood right here at this port, and this device will read it automatically. And this tells you the hemoglobin percent is 14.1. Okay, so that's one way of doing it. That's much more simplistic than it used to be, and it takes away the subjective nature of everybody reading it a different way. At hemoglobinometer, you have to put a blood sample on a slide, stick the slide in the device, and then look through the opening at one end of it, hold it up towards light, and then look at, you would see a light area and a dark area, and where the where you had the divider between the light and dark band. There was a scale, and you would read that scale and say, oh, that's 14.5%. And someone else would say, I think that's 14.9%. And someone else would say, I think it's 14.2%. Whether these devices are everybody's eyeball reads it differently, at least whether these are 100% accurate or not, they're going to be consistent. As long as they're consistent, then they're probably pretty close to accurate. An even more subjective approach used to be using this thing called the Tallquist scale. And this involved taking a sample of blood, a drop of blood, and putting it on a piece of blotter paper, special blotter paper that was in this little book. And then you'd slide that blotter paper underneath this page. These are actually holes in the paper, in the pages here. And you could match the blood sample on the blotter paper to the blood, to the color of the blood here. And so you slide the paper up and down and you read the value off of there and say, oh, it's 15.8 or it's 14.1. Problem was, the longer that blood stayed in, if you weren't certain, the longer that drop of blood stayed in that piece of paper, the darker it got. And so it was, after a while, it was going to start giving you false readings. And this test was very, very subjective. With devices like this, you can read, this isn't much different than measuring blood sugar, a blood glucose meter, by just measuring the amount of hemoglobin present. Very simple procedure. It's consistency. That's what you're looking for, is consistency. Okay. This is the Tallquist scale. I don't think anybody uses it anymore, but it just, we've come a long way in how we evaluate, get these numbers. Okay. So these are, so three things we look at. We look at hematocrit, we look at hemoglobin levels, we look at sedimentation rates. So we're going to be identifying whether or not, is your patient experiencing anemia? Are they experiencing polycythemia? Are they experiencing some sort of inflammatory responses? Are they having an allergic reaction to something? Are they fighting an infection? Do they have enough hemoglobin? And that would be you would compare your hematocrit to your hemoglobin levels simply to see if, that is your patient experiencing anemia? So, very simple procedures to test. Now, another thing we're going to look at is blood typing. Blood types. Blood has different, there are 90 different types of blood. And the typing is based on the presence of these glycocalyc structures that stick up on the surface of the red cell that identify the cell as self. Now, the most common types are the ABO type, and then we also take into consideration Rh factor. ABO gives you type A blood, type B blood, type AB blood, and type O. And then you're either Rh positive or Rh negative. And these all depend on the presence of the antigens, the glycocalyc structures that stick up as identifiers. If you are type A blood, you have A antigens on the surface of your cell announcing to the whole world that you are type A blood. And everybody that has type A blood has the same type of antigens. If you are type B blood, you have a different antigen. And everybody that has type B blood has that antigen. If you're type AB or type O, we have combinations here. If you are Rh factor positive, if you're Rh positive, you don't have, it's sort of counterintuitive here. If you're Rh positive, you don't have the antigen. If you are Rh negative, you have the antigen. I'm sorry, I got that backwards. If you're Rh positive, you have the antigen, but you don't have any kind of reaction to it. I'll get more into that. If you're Rh negative, you don't have the antigen, but you could have a reaction to blood. And that sounds really confusing. So I dug a hole. I'll stop digging, and I'll explain that in better detail here in a second. Okay, forget Rh factors for a second. The two antigens, A and B, determine whether you're going to be A blood, B blood, or AB blood. If you are type A blood, you have A antigens on the surface of your red cells. All your red cells have type A antigens if you're type A blood, telling everybody that you are type A, telling all your cells that you're type A, telling anybody else that uses your blood that it's type A. Your mortal enemy, the mortal enemy of your type A cells is B. B, if you are type A blood, you have A antigens, but you have antibodies. You have proteins in solution that are looking for type B blood cells, red cells with the B antigen in there to attack and destroy. Now, if you're type A blood, you're only going to make A blood. You're not going to make B blood or any other kind. If you're type A blood, you're only going to continue to make type A blood. But if you were accidentally given a transfusion of type B blood, your antibodies, those proteins in there that protect us, the antibodies that are part of our immune response that protect us, would instantly recognize type B blood as foreign and attack it and destroy it. But unfortunately, part of the destroying process is to form clots. And people may die from a transfusion mismatch. It happens about 3 times a year, which doesn't sound like a lot, but when it shouldn't happen at all, it is a lot. So if you're type A blood, you have A antigens and you have B antibodies. You're carrying around these B antibodies just looking for B blood to kill. Fortunately, you will probably never encounter that. If you are type B blood, you have B antigens on your red cells that identify those red cells as type B blood. The antigen has a different shape. It's a glycocalyx for B, and it has a different shape and structure than the type A. This is the B antigen, and it's on anybody that has B blood has those antigens. Now, who is your enemy if you're type B? A. You have A antibodies in solution, because the enemy of type B is A. So you are out there, your antibodies are out there looking for any cell with an A antigen. A cells have B antibodies, B cells have A antibodies. A can't give to B, B can't give to A. Because if you did, in either case, if B gave to A, there'd be a transfusion reaction with the B blood. If A gave to B, there'd be a transfusion reaction with the A blood. A and B can never give to each other because A has the B antibodies, which are going to attack the B blood. B has the A antibodies, which would attack A blood. Third category, though, makes things a little different. Group AB has both A and B antigens. They have the glycocalyx structures on both, for both A and B cells. They also have no antibodies. You couldn't, because if you have if you type AB and you have both antigens, You can't have antibodies. You'd end up attacking yourself all the time. So you have no antibodies. AB blood is considered the universal recipient. A person with AB blood can receive blood from anybody because they have no antibodies. They have no antibodies whatsoever. And that's great. They can take blood from A, they can take blood from B, they can take blood from O. They are the universal recipient. They have no issue on any of the bloods because they don't have any antibodies that would attack. Oh, they have antibodies. They have lots of antibodies. They just don't have antibodies for those types of blood, which is good because that's what they have anyway. They have both types to begin with, or rather, both types of antigens. Last category is type O. No antigens on the red cell. And no glycocalyx sticking up saying, hey, look at me, I'm type O. So they have no antibodies. I mean, they have no antigens. But they also can have A and B antibodies. And that's fine because there are no antigens on the surface of the red cell to trigger the antibodies to attack them. So you have no antigens, but both types of antibodies. O is the universal donor. O can give to anybody because O is not going to trigger an antibody reaction with A or B or AB. O is the universal donor. So O is what is given frequently, well, nearly always, in fact, usually always, to patients if you don't know their blood type, you would give them O. Because if you give them O blood, you can't go wrong. You shouldn't go. If you give them O blood, it's likely you're not going to have any kind of problem. Now, we'll get into the RH factor here in a second. So AB, AB, and O. A can't give to B. B can't give to A. AB can take blood from anybody, and O can give to anybody. If you have the antigen, whatever your antigen is, your antibodies will be the opposite. A antigen, B antibodies. B antigen, A antibodies. If you have both antigens, you have no antibodies. And if you have no antigens, you have both antibodies. So, okay. The antibodies will cause our blood cells to agglutinate. If we encounter foreign red cells, blood will clump together. That's what agglutinate means. They will clump together and form clots. And when the clotting occurs, then it blocks blood flow in tissue. We start having tissue death. The clotting can be so severe that your patient can die. You know, if there's we call it the antigen antibody complexes that form throughout the body. You know, again, it doesn't kill that many every year, but it does kill some. You know. Now, other issues. Well, erythroblastosis fetalis is a condition that occurs dealing with RH factor. I'll get to that in a second. Transfusion reactions. Transfusion reactions occur when you give the wrong blood to a patient. You know, if you give A blood to a B blood patient, you know, it's not supposed to happen. Now, what about RH factor? There are, in RH blood typing, there are antigens present on the surface of the red cell. If you are, there are C, D, and E are the three types of antigens for RH factor. If you have the D antigen, then you, on the surface of your red cell, you are considered RH positive. And that's as far as it goes. Okay, you're RH positive. My blood type is A positive because I've got A antigens and I got the D antigens. So I'm A positive. If I didn't have the D antigens, I'd be A negative. A person that doesn't have the D antigens is RH negative. But there are no antibodies. If you have If you are Rh positive and you have the D antigens, you will not produce antibodies. Okay, you don't produce antibodies if you are Rh positive, because that's, if you're Rh positive, that's the end of the discussion on Rh factor. If you're Rh negative and don't have the D antigen, the only time that you would produce any kind of antibodies and have any kind of concern with the Rh factor is if you are if you are Rh negative and you are accidentally given Rh positive blood. Exposure to the D antigens will trigger the production of antibodies in your blood. So there you are, you're in an accident and you're Rh negative, and instead of giving you Rh negative blood, they're supposed to be giving you O negative because that's the universal donor. O negative blood is the ideal blood for anybody, theoretically. So you're supposed to be given O negative blood, but there's a little bit of confusion in the blood bank that day, and instead of getting O negative, you get O positive. Okay, you get O positive, you recover from your injuries, and you're fine. That O positive blood did nothing to you except trigger the production of antibodies to the Rh antigen. And you may go through the whole rest of your life with no issues. But let's say that you're unfortunate enough to be in an accident again, and the same type of mistake happens, and you're given another unit of Rh positive blood. You're supposed to get, O negative blood, and you get O positive. Now you have antibodies to the Rh antigens. Now your body reacts very quickly to an antigen-antibody complex, and all of a sudden your patient dies because there was this massive response against that positive blood. Rh positive individuals don't have this issue. Rh positive individuals don't produce any kind of antibodies to the Rh antigen. Rh negative individuals don't produce antibodies unless they become sensitized. And sensitization only occurs if they're exposed to Rh positive blood. And it doesn't do anything the first time because it takes about a month to build up enough to produce antibodies so that they can attack the blood. By that time, the transfused blood is all gone. Transfused blood only lasts for about a month. So you're accidentally, you have a patient that's accidentally given O positive instead of O negative. It's the first time they've been exposed to O positive blood in their lives. They're going to produce antibodies because it's foreign blood, but they're not going to have a reaction because by the time they get enough antibodies together to do something, the O positive blood has broken down. But now they are sensitized, ready to respond again. The only other concern we have is with, let me get back up with Rh factor is with an Rh negative female. Rh negative females, if they become pregnant from an Rh positive male, since the Rh factor is genetically determined and Rh positive is always the dominant factor, an Rh positive male will always cause the baby in utero to be Rh positive. If the mother's Rh positive and the father's Rh negative, it's not a problem because the negative Rh factor in the male, that's the recessive trait. The female has the dominant trait. So you don't get Rh negative children from an Rh positive mother and an Rh negative father. To get Rh negative children, you have to have parents that are Rh negative. Now, so you have an Rh negative female and an Rh negative and an Rh positive male. Female becomes pregnant from the male. The baby is Rh positive. The mother is Rh negative. She gets sensitized at birth. She's exposed to blood from the baby at childbirth, and that will sensitize her. And she will start producing antibodies. There is no mixing of blood at all, but there is exposure to the baby's blood at delivery. When the placenta is coming out from coming out of the uterus, breaking away from the uterine wall, there is exposure there to the baby's blood to the mother. And if the baby is positive and the mother is negative, she becomes sensitized. No problem for baby number one. Baby number two, however, if she gets pregnant again to the same father, baby number two now has a risk, because while the while blood cells don't go back and forth across the placenta, antibodies can. And so the Rh negative female, that is sensitized to Rh positive blood, her antibodies can attack the developing baby in utero and kill it. That's what we call erythroblastosis fatalis, and it can kill very quickly. So the way to get around that is there's a drug called Rogam. It's an injectable drug that Rh negative females are usually given during every pregnancy to guarantee that they don't have any Rh positive antibodies. So if you have a patient that's a female patient that is Rh negative and she becomes pregnant, then you administer Rogam to her. So that will destroy any Rh positive antibodies. So she has no complications, and you simply do this at every pregnancy. Because you don't know, your patient, you don't know her history from childbirth up to the present. You don't know if she's ever been exposed to positive blood, so you don't take that chance. You just, as a phrase that we all are tired of hearing, out of an abundance of caution, you administer the Rogam. The Rogam destroys any antibodies that might be present, and so she can have a successful pregnancy. She can have as many successful pregnancies as she desires. Okay. Blood types. Cell types, I should say. Cell types, we have how many? Well, I try to keep this real simple. Red cells, about 5 million per cubic millimeter of blood, about 5 million. And white cells, about 5,000. Just, this is just sort of a rule of thumb, 5 million to 5,000. Easy way to remember it. That says 4,000 to 11,000, that's fine. But 5,000 is a nice number right in the middle. 5 million, right in the middle. 5 million red cells in the cubic millimeter, 5,000 white cells. Now the order of, you can say 500,000 platelets if you want to use that number too, because that's still within the range of normalcy for platelets. So red cells 5 million, white cells 5,000, platelets 500,000. The white cells occur the most common type in order of appearance. Most common type are the neutrophils, lymphocytes, monocytes, eosinophils, and basophils. That's the order of the appearance of the white cells. The neutrophils are the most common. The basophils are the least common. This one slide shows you all types of blood cells. You have the red cells, you have the white cells, and you have the platelets. You would never see in a blood smear, which is what you call the slide, how the slide is made. You would never see all these white cells together. If you saw this many red cells, you would likely just see one white cell, and it would usually be a neutrophil. The neutrophil is the most common type of white cell. It looks something like this. most common type of white cell. And if your field of view had all these red cells, you would probably have 1 or 2 platelets, and you would probably have 1 white cell. You'd never have, in a healthy individual, you'd never have all 6 of these, all 5 of these together. So. There's your erythrocyte, the most common of all the blood cells, 5 million blood cells in a cubic millimeter. It is what we call a biconcave disc. You can see it looks like a donut that it doesn't have a hole in the middle, but it has a big dimple on both sides. The concave depression on both sides allows increased surface area for picking up and giving off oxygen. Nothing there, just a big sack of hemoglobin. You can see this is what a normal smear of blood would look like. Look at all the red cells. And 1 neutrophil right here. A lot of little platelets, these little purple things are the platelets. 1 neutrophil, a healthy individual blood sample would look something like this. Lots of red cells or erythrocytes. 1 white cell, usually the neutrophil, and lots of little platelets. Because you get about 500,000 platelets. There are the platelets, little purple. Back one here. These little things, these are cell fragments. We'll talk about that in lecture. But they are cell fragments from the same stem cell that gave you all 5 white cells and the red cells. And all platelets do is work on protecting us from bleeding. They form a plug. When they become stimulated, they form a plug to block loss of blood. Now, easy way to remember the order. The mnemonic here that works very easily deals with monkeys and bananas. Never let monkeys eat bananas. N, never, neutrophils. L, lymphocytes. M, monkeys for monocytes. Eat, eosinophils. And bananas, basophils. Never let monkeys eat bananas. I don't know what we have against monkeys and why we don't like bananas, but this is the mnemonic that lets you remember the order from the most common white cell to the least common white cell. Neutrophils are easy to spot. They have a very busy nucleus. The nucleus usually has 3 parts to it. There's 3 lobes in here. Again, it's the most common of the white cells. Probably 55 to 65% of all white cells are neutrophils. Again, there we see 4 neutrophils together right here. Somewhat unusual to see 4 white cells that close together. And also the fact that we're seeing rouleau formations on these red cells leads me to believe that there's probably an infection going on somewhere. Because the first cells that show up in an infection, first white cells are going to be these neutrophils. And the fact that we have sedimentation taking place here on these red cells tells me that there's something going on. Okay. Second most common are the lymphocytes, the let in never let. Lymphocytes are either A cells or B cells. Can't tell them apart by looking at them. They have a very large nucleus. They have just a halo of cytoplasm present here. And these are going to be the B cells or the T cells. These are the antibody producers or the cell killers. So it doesn't look like much is going on because normal amount of platelets and lots of red cells and 1 white cell. This is the second most common. Probably about 30 to 35% of white cells are lymphocytes. Again, there's the lymphocyte. The nucleus is large. It fills it fills nearly the whole cell in here. The monocytes the third category, the nucleus is shaped like a kidney bean or like a horseshoe. It is a macrophage, means it hunts down things and destroys them and eats them. It's large, it's a big cell. And it is what's going to show up when we have infection going on. We're going to see these attacking foreign cells or infected cells, very, very big. This is a monocyte right here. Horseshoe or kidney bean shaped nucleus. When you spot them, they're very distinctive. They're harder to spot because they're the third most common type. So you're dropping down, it's under 10% now. The eosinophils have 2 lobes instead of 3. Eosinophils biology, you see these show up in 2 conditions, allergic reaction and parasitic worms. You have a patient who's been experiencing weight loss and fatigue and constant hunger, and you do blood work and you see these, maybe they have a parasite that's living in their gut, or maybe they're having some sort of chronic allergic reaction to something. Again, they're going to show up either in allergic reactions or in parasitic infections with usually worms. There's another eosinophil there in the 2 lobes. And of course, the last one, the least common, the basophil, looks like a blackberry. It is the hardest one to find. You can spend hours looking for one of these. Invariably, just as soon as you find it, I've had my experiences where I found one looking under the slide, and then I bumped the slide or something, and then lost it because they're very, very infrequent in appearance. But they are distinctive. All those purple spots there, they look like, to me, they look like a blackberry. Now here's a couple of conditions that we see, because you can tell a lot about the health of a patient just by looking at their blood sample. This is acute leukemia. Acute leukemia, more prone in children, a quicker disease process. Again, success rates and death rates for leukemias are well under 5%. It used to be 95% mortality and 5% survival. Now it's the opposite. It's probably even higher than that. 2 types of leukemias, acute and chronic. Acute tends to affect children, chronic tends to affect adults. With leukemia, since it's a type of cancer of the blood, what it does is causes overproduction of ineffective, essentially useless white cells. Note these cells here. First of all, you should only have 1 or 2 white cells in this smear. But here we see cell division and mitosis taking place with 3 cells. Here we see what may be a monocyte and another monocyte. Here we see an ill-defined cell. Most of these cells look exactly the same, and you notice that they're all going through various stages of mitosis and cell division. Rapid cell growth. Also, the red cells are all clumped together in rouleau formations because they're fighting. There's an inflammatory response going on here. So this is leukemia. Again, it's a malignancy in the bone marrow where white blood cells are overproduced to the exclusion of everything else. Very little red cell production. The white cells, however, are not effective because they are all immature and they're consistent in that shape. Call them atypical leukocytes. The rouleau formations are present. Very few normal-looking red cells. That's one of the other characteristics here of leukemia, is that we overproduce white cells and we underproduce red cells. Patients with leukemia often die from complications from ordinary infections because their immune system isn't functioning because the lymphocytes aren't present to fight off pathogens. And they can't carry enough oxygen because they don't have enough red cells. Here we see overproduction of red cells. This is polycythemia. We have way too many red cells. Again, this is also a malignancy of the bone marrow. Here we're overproducing red cells to the exclusion of white cells. And we see what may be a basophil here, a lymphocyte. Don't know what those two are. Again, those are atypical. So with overproducing red cells with a hematocrit above 70 or 80%, these patients are going to clot frequently. Clots form everywhere in their body. Sickle cell disease caused by production of defective hemoglobin. As I talked about in AP1, sickle cell disease is caused by the absence of glutamic acid in the number 6 spot in the amino acid chain. Glutamic acid should be there. Instead, it's valine. One little mistake, the chain is about 360 amino acids long. One little mistake at the number 6 spot makes everything defective. It reduces the oxygen carrying capacity of the hemoglobin. It causes the hemoglobin to distort its shape. When the individual becomes physically stressed, the red cells assume this sickle shape and can't carry adequate amounts of oxygen. Plus, they become brittle and they hurt going through capillaries. Red cells have to be squishy and they can't squish. And that is everything on human blood as far as lab goes. Let me get out of here. Any questions on this? We'll spend a lot of time in lecture talking about this in greater detail, but this is what they look like. This is what the cells look like. If we were in a lab on the ground, I'd have the scopes out. You'd be looking at something very similar to this. You should be able to tell me, you should be able to look at this and identify the conditions and the different types of cells. So, okay. Any questions on any of this? We've finished the first unit now on for AP2 Lab. And I will look and see. I think I set the deadline for, I'm not going to do it off the top of my head. As soon as the lecture test ends, I'm going to go ahead and open up the lab for 10 days for you. So in the meantime, I'm going to get us out of here. So last call, any questions on anything? If you think of something, you can always send me an email and I'll get back to you. So, and again, I thank you for your patience with me canceling the lecture today. On Wednesday, we will start up on Repro, I promise. So, okay. So I'll see you all on Wednesday.